He was 69 years old. He had just had a checkup 3 weeks before he died. His doctor told him everything looked clean: blood pressure manageable, cholesterol within acceptable range, heart rhythm normal on the ECG. His wife said he had seemed perfectly well that evening. They ate dinner together, watched something on television, talked about plans for the weekend. He kissed her goodnight, he went to bed, and he did not wake up. The cause of death was a massive cardiac event, the kind that strikes in the quiet hours and leaves nothing for anyone to do. His family was left trying to understand how a man who had been told he was fine 3 weeks earlier could be gone by morning. There was no clutched chest, no moment of alarm, no warning, just the terrible stillness of a morning that should have been ordinary. And at the center of it, a habit he had practiced every single night for years, one that research now clearly links to exactly this kind of nocturnal cardiac event. A habit so ordinary that the idea of it being dangerous had simply never entered the conversation. I want to tell you about a second person, a woman, 64 years old, who woke at 2 a.m. with her heart hammering so hard she thought she was dying. She called an ambulance. The paramedics found her blood pressure at a level that alarmed them. She survived. When the cardiologist sat with her afterward and asked about her evenings and her habits, she described something she had done every night for years without imagining it could be connected to anything happening in her heart. When he explained the mechanism to her, she sat very still. And then she said, "Nobody ever told me this, not once. In 64 years, nobody ever told me." I am sharing both of these stories with you today because I have heard versions of them more times than I can count. And every time, at the center of the story is the same habit. A habit so completely built into the rhythm of daily life for most older adults that its cardiovascular danger has never entered the conversation. The man who died was not unlucky. He died because a specific, identifiable, modifiable habit was loading his cardiovascular system for failure every single night, and no one had ever warned him. I am here to warn you. Please stay with me. The American Heart Association has documented for decades what cardiologists call nocturnal cardiovascular vulnerability, the well-established phenomenon in which the risk of heart attack and stroke rises sharply during the sleeping hours, particularly between midnight and 6 a.m. This is not fringe research. It is a validated, clinically recognized reality. During these hours, the body undergoes hormonal shifts and autonomic transitions that a healthy young cardiovascular system manages smoothly. In an older adult whose system has already accumulated years of silent wear, those same shifts can become dangerous. The National Heart, Lung, and Blood Institute has been equally specific about the central mechanism. In a healthy cardiovascular system, blood pressure follows a predictable daily rhythm. It rises during active waking hours and dips during sleep, typically falling 10 to 20% from the daytime peak. This nocturnal dip is biologically essential. It is the window during which the heart approximates genuine rest. The arterial walls decompress from the sustained pressure of waking activity, and the vascular system performs the maintenance it cannot manage during active hours. When this dip does not happen, when blood pressure remains elevated or actually rises during sleep, the consequences are serious and well documented. Research estimates that between 30 and 50% of adults over 60 experience this non-dipping pattern. A landmark study published in the journal Hypertension followed more than 3,000 adults with an average age of 66 over 4 years and found that those with non-dipping nocturnal blood pressure had a cardiovascular event risk, heart attack, stroke, sudden cardiac death, more than double that of participants whose pressure dipped normally. Not 10% higher, more than double. And this elevated risk was present regardless of how well their daytime blood pressure was controlled. What makes this particularly sobering is that the non-dipping pattern produces no symptoms the person can feel during the night. There is no chest tightness, no alarm, no warning signal. The individual lies in bed, believing they are resting, while their blood pressure holds at a level that, had it been recorded in a doctor's office, would have prompted immediate clinical concern. The body has no overnight alarm for sustained vascular pressure, and for a heart already working harder than it should, hour after hour, night after night, the cumulative toll accumulates invisibly until it is not invisible at all. A second study, published in the European Heart Journal, examined ambulatory blood pressure data collected over full 24-hour periods in more than 7,000 adults across multiple countries. The conclusion was unambiguous. Nocturnal blood pressure was a stronger independent predictor of cardiovascular mortality than daytime blood pressure across every age group studied, and the predictive gap widened with age. The older the patient, the more their nighttime pressure mattered, and the less their daytime reading alone told the clinical story. What is driving the non-dipping pattern in the majority of otherwise healthy older adults who have it? The research identifies the cause clearly, consistently, and across multiple independent cohorts. It is not primarily a medication issue. It is not primarily genetic. It is a specific daily behavior practiced in the evening hours, so unremarkable, so normalized, that most people have never once connected it to their cardiovascular risk. That habit is eating a substantial meal within 2 to 3 hours of going to sleep. Let me be clear about something first. Most adults over 60 who carry cardiovascular risk are doing the right things within the framework they have been given. They are taking their medications, they are attending checkups, many are monitoring blood pressure at home, watching their sodium, trying to exercise, and their doctors, for the most part, are doing exactly what the clinical system equips them to do, measuring daytime blood pressure, running cholesterol panels, recording resting ECGs, adjusting medications based on office readings. These interventions have real, documented value. I am not here to dismiss any of them. But here is the structural gap that most patients never hear about. Every single one of those interventions addresses what your heart is doing while you are awake, upright, and measurable. Almost none of the standard clinical conversation addresses what your cardiovascular system is doing during the 6 to 8 hours every night when you are horizontal, unconscious, and completely unable to call for help if something goes wrong. The prescription was calibrated around your 2:30 appointment. Nobody has looked at what your blood pressure is doing at 2:30 in the morning. A review published in the European Heart Journal quantified this gap precisely. The authors found that in large cohorts of adults over 60, nocturnal blood pressure was a significantly stronger independent predictor of cardiovascular mortality than office-measured daytime pressure, and that a meaningful proportion of individuals classified as having well-controlled hypertension based on daytime readings were in fact experiencing dangerous nocturnal pressure elevations their standard monitoring protocol was entirely missing. Researchers call this masked nocturnal hypertension. Estimates suggest it affects 15 to 30% of adults currently on antihypertensive medication who believe their pressure is under control. The reason this gap persists is not physician negligence. A standard appointment allows 8 to 12 minutes of clinical conversation. The medication adjustment, the cholesterol target, the ECG reading, these are the prioritized deliverables of that window. The nuanced behavioral conversation about evening habits and nocturnal cardiovascular risk simply does not fit. And so, night after night, the habit continues, the pressure climbs, and the damage accumulates in the dark. The research identifies the cause clearly, but nobody sat down with the patient and explained what eating a heavy meal at 9 o'clock is doing to their heart at 2 in the morning, until today. My name is Dr. Nicole Harper, and I have spent years working with adults over 60 who are serious about understanding and protecting their cardiovascular health, not just managing numbers on a chart, but genuinely reducing their risk of the events that end lives without warning in the night when no one is there to help. Today, I am going to walk you through exactly what late night eating does to your cardiovascular system while you sleep, why these mechanisms are specifically and disproportionately dangerous for adults over 60, the precise biological pathways connecting your evening meal to your risk of heart attack and stroke, who carries the highest risk, and the 5 warning signs that your body may already be sending you that deserve immediate attention. Before we continue, drop your city or country in the comments right now. We are building a community of people who take their cardiovascular health seriously, and I read every comment personally. And please hear this clearly. If you have a diagnosed heart condition, a history of heart attack or stroke, atrial fibrillation, heart failure, or if you are on any cardiovascular medication, speak with your cardiologist before making changes to your routine based on what I share today. Do not adjust or stop any medication on the basis of this video. What I am offering you is education grounded in published research. It is not a replacement for your personal medical care. Now, let me take you through the mechanisms one by one, because once you understand what is happening inside your body during those overnight hours, you will never approach this the same way again. The habit at the center of everything I am about to describe is consuming a substantial meal within 2 to 3 hours of sleep onset. Not a light snack, a proper meal, the kind that constitutes a significant portion of a day's caloric intake that involves meaningful quantities of carbohydrate and protein that requires the full deployment of your digestive system to process. Most adults over 60 do this routinely. Many eat their largest meal of the day in the evening and go to bed 2 hours later. For most of them, this pattern has been normal for decades. The idea that it carries specific serious cardiovascular risk during the overnight hours has simply never entered the conversation. That invisibility is what makes it dangerous. The damage does not happen at the dinner table. It happens at midnight, at 2 in the morning, in the hours when your cardiovascular system is working harder than anyone around you knows, and when any intervention is hours away. The most dangerous habits are the ones that feel completely harmless right up until they are not. And here is the part that matters most before we get into the biology. The risk is not theoretical. It is not a small elevation in a statistical model. It is a documented, reproducible, clinically significant increase in the probability of the event that most older adults fear above almost everything else. A cardiac event in the night, alone, with no warning and no time for intervention. Understanding why that risk exists, mechanistically, is what makes the solution not just convincing, but impossible to ignore. When you eat a substantial meal, your body initiates a coordinated physiological response. Blood flow redirects toward the gastrointestinal tract. The sympathetic nervous system, the branch responsible for alertness and cardiovascular activation, ramps up to coordinate digestion. Heart rate increases modestly, and in compensation for the peripheral vascular changes of digestion, systemic blood pressure rises. This is called postprandial hypertension, the documented blood pressure elevation following a substantial meal. And in a young, healthy adult, it is a smoothly managed, transient response. In adults over 60, 3 age-related changes transform this routine fluctuation into a sustained cardiovascular burden. First, baroreceptor sensitivity, the precision of the blood vessel pressure sensors that signal the body to compensate, declines with age, meaning the compensating response arrives more slowly and with less precision. Second, arterial wall elasticity is reduced in older adults, so pressure waves travel more rigidly through the vascular tree with less dampening. Third, overall autonomic agility, the speed of real-time cardiovascular adjustments, is diminished. The combined result is that the postprandial pressure surge in an adult over 60 is larger in magnitude, longer in duration, and harder to buffer than in a younger person. Research documents that this surge can persist for 3 to 5 hours in older adults. Apply that to a 9 o'clock dinner. The pressure peaks around 11. It is still elevated at 1 in the morning, at 2, at 3, operating at full force during precisely the window the American Heart Association identifies as carrying the highest risk of fatal cardiac events. The Hypertension Journal study, 3,000 plus participants, average age 66, 4-year follow-up, found more than double the cardiovascular event risk in non-dippers compared to those whose pressure dipped normally. Your daytime readings said you were fine. Your 2 a.m. readings told a different story. To put this in the plainest possible terms, every time you eat a substantial evening meal and go to bed 2 hours later, You are sending your heart into its most cardiovascular, vulnerable window of the day, carrying an elevated pressure load it was not designed to sustain overnight. Not occasionally, every single night the pattern continues, and your doctor, reviewing your acceptable afternoon blood pressure reading, has no visibility into it. Running in parallel to the blood pressure surge is a second cardiovascular pathway. When you eat a carbohydrate-containing meal, your pancreas releases insulin to manage incoming glucose. In adults over 60, insulin sensitivity is typically reduced, so the pancreas compensates with higher insulin output to achieve the same glucose clearing effect. That elevated nocturnal insulin level has three simultaneous cardiovascular consequences. First, it promotes sodium retention in the kidneys, increasing fluid retention, blood volume, and blood pressure, compounding the postprandial surge directly. Second, it activates the sympathetic nervous system further, adding a third independent pressure-raising signal from the same meal. Third, it triggers endothelial inflammation, a pro-inflammatory response in the inner lining of your blood vessel walls. Gerontologists call the chronic version of this pattern inflammaging, the low-grade arterial inflammation now recognized as the single most consistent biological substrate of age-related cardiovascular disease. It is measurable in the blood as elevated C-reactive protein and interleukin-6. A study published in the Journal of the American College of Cardiology found that adults over 60 who consistently ate their last substantial meal within 2 hours of bedtime showed significantly elevated CRP and interleukin-6 in morning blood draws compared to those who finished eating at least 3 hours before sleep, even after controlling for total caloric intake and dietary composition. The timing of the meal, independent of what the meal contained, was driving the inflammatory signal. A nightly inflammatory trigger applied to arterial walls already carrying decades of cumulative wear. Every night, for years. The third mechanism receives the least attention and may be the most acutely dangerous. It involves the vagus nerve, the longest cranial nerve in the body, running from the brainstem through the chest cavity directly alongside the heart and into the abdomen. It is the primary highway of the parasympathetic nervous system and plays a central role in regulating heart rate and cardiac rhythm through its cardiac branches. When your stomach is distended with food, the stretch receptors in the stomach wall are vagally innervated, meaning the mechanical pressure of a full stomach directly and reflexively stimulates vagal fibers. In a young adult with a resilient, well-regulated autonomic system, this stimulation is mild and smoothly absorbed. In an older adult whose arterial walls are already stiffened, whose baroreceptors are already blunted, whose nocturnal blood pressure is already elevated by mechanisms 1 and 2, that same vagal stimulation lands in a completely different cardiovascular environment. An environment already under pressure, already in the window of peak nocturnal vulnerability. And in that environment, vagal stimulation from a distended stomach can trigger cardiac arrhythmias, abnormal heart rhythms, conduction pauses, and in vulnerable individuals, potentially fatal rhythm disturbances. A study published in Heart Rhythm examined patients who had experienced documented nocturnal arrhythmic events, episodes captured on cardiac monitors during sleep, against matched controls. Patients in the arrhythmic event group showed substantially higher frequency of substantial late evening meals in the 48 hours preceding their events. The association between a full stomach, vagal activation, and nocturnal arrhythmia in older adults was direct and consistent. And now consider all three mechanisms together: postprandial pressure surge, nocturnal arterial inflammation, vagal arrhythmia risk, running simultaneously, reaching their combined peak in the same 2 to 4 hour overnight window in a body that is horizontal, unconscious, and hours from any possible intervention. This is the cardiovascular environment that a late heavy meal creates every single night for older adults who have never been warned about it. Not every older adult faces equal risk, but 5 specific profiles carry substantially elevated vulnerability and deserve to be named directly. Adults over 65. The compounding of reduced baroreceptor sensitivity, arterial stiffening, and diminished autonomic agility is progressive. The further past 60 you are, the less buffering capacity your cardiovascular system has for the postprandial surge. Age alone is a meaningful risk modifier here. The same meal that a 62-year-old might manage with modest nocturnal elevation could push a 72-year-old into a clinically dangerous range. Anyone with diagnosed hypertension, even well controlled, your daytime readings are acceptable because your medication was calibrated around them. But you are starting every night from a higher baseline than a person with naturally normal pressure. Any nocturnal surge driven by a late meal pushes you further into dangerous territory from that higher starting point. The buffer between your controlled baseline and a dangerous nocturnal peak is narrower than your office readings suggest. Anyone with type 2 diabetes or prediabetes. Insulin dysregulation is the defining feature of both conditions. The elevated nocturnal insulin response and the compounded sodium retention, sympathetic activation, and endothelial inflammation that follow are amplified in anyone whose insulin sensitivity is already compromised. The inflammatory cascade is not only more pronounced, it is operating on top of the existing vascular damage that glucose dysregulation produces independently. Anyone with a history of cardiac arrhythmia or irregular heartbeat. If your heart has already demonstrated vulnerability to rhythm disturbance, atrial fibrillation, supraventricular tachycardia, heart block, or any documented arrhythmic condition, the vagal stimulation mechanism from late-night eating represents a specific, named, elevated risk. Your cardiac electrical system has already shown that it can be disrupted. The conditions created by a late heavy meal are specifically conducive to that disruption recurring. Anyone with acid reflux or GERD. Gastroesophageal reflux at night is not merely a digestive inconvenience. Each reflux event directly stimulates vagal nerve fibers in the esophageal wall. Combined with the stomach distension vagal activation and the nocturnal pressure elevation already described, recurrent reflux adds a third and fourth vagal activation signal to a system already under strain. The feedback loop between late eating, horizontal positioning, reflux, and arrhythmia risk is tight, documented, and clinically relevant. If you recognize yourself in two or more of these profiles, this is not information to file away for later. This is information to act on tonight. Step 1. Finish your last substantial meal at least 3 hours before your target bedtime. Not 2 hours, 3. The postprandial pressure curve in adults over 60 takes approximately 2.5 to 3 hours to return toward baseline after a moderate meal. 2 hours means the surge is still active as you lie down. 3 hours places the evidence-supported minimum distance between the pressure peak and the most vulnerable overnight window. If your current pattern has you eating at 8 and going to bed at 9:30, either move dinner earlier or bedtime later. The specific times matter less than the 3-hour gap between them. Step 2. If you are genuinely hungry in the evening, eat small and eat specifically. Volume drives vagal stimulation. A small snack does not produce meaningful stomach distension. A few unsalted walnuts, a small portion of avocado, plain yogurt without added sugar, or a few slices of oily fish produce a fraction of the insulin response, a fraction of the postprandial pressure surge, and no meaningful vagal activation compared to a full meal. Satisfy genuine hunger without triggering the full digestive and cardiovascular cascade. Step 3. Actively manage sodium in your evening meal. Sodium drives fluid retention. Fluid retention drives blood volume. Blood volume drives pressure. Restaurant meals, takeaway food, and processed foods routinely deliver 2/3 of the entire recommended daily sodium intake in a single serving, often without tasting particularly salty because the sodium is used as a preservative. If you are eating in the evening, cook simply. Season with herbs rather than salt. This single adjustment meaningfully reduces the blood pressure burden of an evening meal. Step 4. Set a hard alcohol cutoff at least 2 hours before bed. Alcohol is vasodilatory in the short term. Blood pressure dips briefly. The person feels calm and drowsy. This is why many older adults believe it helps them sleep. What follows as the alcohol is metabolized, typically 1 to 2 hours after consumption, is a blood pressure rebound, disrupted heart rate variability, and suppression of the deep restorative sleep stages the cardiovascular system depends on for overnight recovery. A study published in Alcoholism, Clinical and Experimental Research found that even one standard drink within 3 hours of sleep significantly disrupted heart rate variability in adults over 60. The combination of alcohol metabolism and a full stomach operating in the overnight hours simultaneously is one of the most cardiovascular stressful conditions an older adult can create without realizing it. Step 5. Sleep on your left side. Left side sleeping reduces gravitational pressure of stomach contents against the lower esophageal sphincter, dramatically reducing nocturnal reflux and the associated vagal activation. A study published in the Journal of Clinical Gastroenterology found left side sleeping reduced nocturnal acid exposure by more than 70% compared to right side sleeping in adults with reflux. It also positions the heart to reduce the mechanical workload of the left ventricle during overnight pumping. Zero cost, zero effort, available tonight. For some of you watching, the mechanisms I have described are not future risks. They are already happening. Your body may already be sending you signals that your cardiovascular system is under nocturnal stress. These signals are not dramatic. They do not feel like emergencies. And that is precisely why most people dismiss them, attribute them to aging, and move on without ever connecting them to what is happening in their heart at 2 a.m. Warning sign 1. You wake up with a headache, particularly at the back of the head or temples, before you have stood up, before you have had caffeine, before any physical cause has presented itself. Morning headaches present on waking before any activity are a recognized clinical indicator of elevated nocturnal blood pressure. The sustained pressure during overnight hours creates vascular pressure on the cerebral circulation that manifests as the headache you wake with. This is distinct from a tension headache, which arrives as you engage with the day. If this is consistent, more than 2 or 3 times per week, do not attribute it to stress and move on. Request ambulatory blood pressure monitoring from your doctor. Ask specifically for a 24-hour reading that captures nighttime pressure. What it shows may be very different from your daytime office readings. Warning sign 2. You wake in the night or early morning with your heart racing, pounding, or beating in an irregular or alarming way. Nocturnal palpitations are the direct felt experience of the vagal arrhythmia mechanism described in Mechanism 3. Occasional palpitations, a brief flutter, a skipped beat, are common and often benign in older adults. Recurrent, alarming, sleep-disrupting palpitations that wake you consistently are different. Begin keeping a log: time, duration, what you ate that evening, and when. Bring that log to your cardiologist. The pattern of relationship to your evening meal, documented in your own observations, is among the most diagnostically useful information you can provide. Warning sign 3. You wake from what should have been adequate sleep, feeling genuinely unrefreshed, heavy, foggy, tired in a way that coffee barely touches, consistently, regardless of how many hours you slept. Most people attribute this to aging and accept it. In many cases, it is not aging. It is a cardiovascular system that spent the overnight hours managing elevated pressure, processing a late meal, and navigating inflammatory stress rather than completing the restorative deep sleep cycles it needed. The body was working too hard to rest. If this is consistent across 2 weeks or more, and sleep duration is not the issue, the quality of what is happening during that sleep deserves investigation, not reassurance that this is simply what getting older feels like. Warning sign 4. You experience heartburn or acid reflux regularly after lying down at night. This is almost universally understood as a digestive inconvenience and almost never discussed as the cardiovascular signal it can be. Each nocturnal reflux event directly stimulates vagal nerve fibers in the esophageal wall. In an older adult already managing nocturnal blood pressure elevation and stomach distension from a late meal, That vagal stimulation adds compounding arrhythmia and pressure risk that antacids do not address. If you are taking antacids regularly at night, please bring that pattern to your doctor in the context of your overall cardiovascular risk profile, not only as a gastrointestinal symptom. Warning sign 5. You snore heavily, or someone who has slept beside you has told you that you stop breathing in the night, that you gasp, that there are pauses, that the sound of your breathing changes in a way that alarmed them. I am going to be more direct about this sign than any other. Sleep apnea is not a nuisance condition. It is one of the most potent independent risk factors for nocturnal hypertension, cardiac arrhythmia, heart attack, and stroke in adults over 60 that exists in the cardiovascular literature. Each apneic episode produces an acute blood pressure surge and explosive sympathetic activation. In a cardiovascular system already burdened by late meal mechanisms, each episode is an additional insult on an already strained system. If you snore heavily and have never had a sleep study, pursue one. If your partner has told you that you stop breathing in the night, do not file that information away. Act on it. This is not optional. This is urgent. If you have recognized yourself in 2 or more of these warning signs, please do not finish this video and move on with your evening as though nothing has changed. Make the call tomorrow morning, book the appointment, ask specifically about ambulatory blood pressure monitoring and nocturnal cardiovascular risk. The information exists, the tests exist, the interventions exist. What has been missing until today is the conversation that connects your evening habits to your overnight cardiovascular reality. I want to come back to the man I told you about at the beginning. 69 years old, clean checkup 3 weeks before, a normal evening with his family, good night, and then nothing. What stays with me every time I think about him and the people like him is not the tragedy of the loss itself. It is the preventability. The research existed. The mechanism was understood. The protocol I walked you through today was available. What was missing was one conversation. One honest, specific, unhurried conversation at the right time. And nobody had it with him. You are having that conversation today, and because you are, the outcome does not have to be the same. Finish eating 3 hours before you sleep, not 2, 3. If you must eat in the evening, keep it small and specific. Watch your sodium. Put the alcohol down 2 hours before bed and understand what its rebound effect is actually doing to your heart. Sleep on your left side. And if you recognize yourself in any of the 5 warning signs, the morning headache, the nocturnal palpitations, the unrefreshing sleep, the reflux, the breathing pauses your partner has mentioned, please take that recognition seriously and make the call tomorrow morning. Your heart has been working for you every second of every night for your entire life, without being asked, without taking a single night off, without ever asking for anything in return. The very least you can do is stop making its job harder during the hours when it is most vulnerable, most alone, and least able to ask for help. I want to hear from you now. Did anything I shared today surprise you? Was there a mechanism, a warning sign, a connection here that you had genuinely never heard before? Leave your answer in the comments. I read every single one personally. If this video may have made a difference today, please hit the like button and subscribe for more evidence-informed content on protecting your health as you age. And share this immediately with every person over 60 in your life. Do not wait until the next time you see them. Send it now. You do not know whose night, whose heart this information might change. This is Dr. Nicole Harper. Take care of your heart. I will see you in the next one.